to this webinar on an update in the surveillance, clinical management, and neurological evaluation of acute flaccid paralysis. Why? Because this is an important topic today in the region of the Americas, in particular because we are in a situation in the Americas in which we face the risk of polio being again a public health threat, and part of this well coordinated and structured response that we need, in which vaccination programs are at the heart of the solution. We start with clinical identification, clinical monitoring and treatment, and also referral of patients, studies, diagnosis, and the proper reporting to the epidemiological surveillance programs within the countries. Within this broad context, we are going to focus on these clinical differential diagnosis and also the epidemiological phase to be able to detect, report, and contain the emergence of potential AFP cases in the region. We have a broad agenda today, but before that, I would like to offer you some very simple instructions for the use of Zoom. So you can use interpretation if you wish. You can use the button at the bottom of the screen whereby you can choose the language of your choice, English or Spanish. And we also invite you to ask your questions using the Q&A button. And there, please do include your questions, your comments. We'll try to answer those questions live as much as we can, but we do have a lot of participants and we have limited time. So it is quite likely that many of the questions are answered later on via email. So without further ado, we are going to welcome you warmly to this seminar. Dr. Salas Peraza is the executive manager, the director of the Comprehensive Immunization Program here at PAHO, Regional Office of the World Health Organization for the Americas. Dr. Salas, you have the floor. Warm welcome to all of the participants. I would like to thank Dr. Alvarez, Dr. Pardo for accepting to help us and refresh the knowledge we have to be able to strengthen, as Dr. Pilar Ramon mentioned, that capacity we have to detect cases timely, suspect cases of polio. And the situation, as Dr. Pilar mentioned, is quite concerning in the Americas. The coverage, the vaccine coverage for polio is decreasing. Even before the pandemic, we had about, for the last 10 years or so, coverage has not been optimal, and this also worsened during the pandemic. So we have some important work to do, given the last appraisal by the RCC, our regional committee on polio. We have 12 countries that have a high or very high risk of having a case of polio, a reintroduction of polio, and the other countries also need to analyze this internally, because sometimes it is not only having a high number within the country, but also to analyze this subnationally to determine the pockets of susceptible cases within children or even teenagers and adults that are lagging behind and that do not have a complete vaccination schedule. We're not used to seeing polio, and that's the reason why it is necessary to carry out those activities for the doctors and the medical staff to have first-hand information, first-hand tools to be able to detect polio cases, given these decrease in sustained vaccine coverage. It is important to recover, to increase vaccination coverage, but also surveillance systems need to be strengthened, and also the ability to detect cases has to be on top of all. So we need to be extremely careful. This is public health for our region, something extremely important. And without further comments, I just want to wish you the very best for this session. Thank you. Thank you, Dr. Salas. We thank you for your remarks that remind us of the importance of vaccination and also the importance of maintaining excellent coverages in the region which are being affected by the pandemic and what happened during the pandemic. So the objectives of this seminar are to improve detection, management, and follow-up of cases of AFP, and we are now going to better understand the context and the importance of reporting national health authorities. We welcome all of the participants that we know are attending from different countries in Latin America, the US, and Canada. We also heard that we have some European participants. We know that they are health professionals from various levels of care, and it is important to have this multidisciplinary approach. Without further ado, I am going to give the floor to Dr. Gloria, who is also an advisor, and it is a member of the special immunization program here at PAHO, and she is in charge of laboratory networks for the surveillance of measles, polio, and various diseases that are vaccine preventable. She is also in charge of the surveillance for acute flaccid paralysis. When you wish, we are ready to listen to you. And I once again encourage you to send your comments through the Q&A button. Thank you, Pilar. Good morning. It is a pleasure to have so many participants here throughout the region, as Pilar mentioned, and also from other areas of the world. I know that you are all eager to start with the surveillance of acute flaccid paralysis in the current situation. But before we refer to surveillance, we are going to refer to some issues that have to do with the virus and the disease, the progress made in the eradication of polio, and then we will better draw the situation of surveillance for acute flaccid paralysis and the situation we have in the region. We need to recall that the word polio is used indistinguishably, sometimes to refer to poliovirus, but in other cases to refer to polio and the disease. And we need to remember this because depending on the context, we are referring to polio and as the agent or the disease. We also need to recall that the virus is an RNA virus that is part of the enterovirus genre and part of the picornaviri family. We have serotypes 1, 2, and 3, and the type of immunity for one serotype does not protect against the other serotypes. It is also important to recall that this virus only attacks people that the person is the only host of the disease. The transmission is person to person, usually orally and also by some through the feces. We should also remember that polio is an infectious disease caused by some of these polioviruses that invades the nervous system and that may lead to permanent paralysis, but that most of the diseases are asymptomatic and only 30% lead to some suggestive symptoms such as neurosis, or 1 out of 200 infections may produce paralysis, and this paralysis may be permanent and also lead to death. So if we think of poliomyelitis, we can say that this is the result of wild viruses, wild PV because of the acronym, and we call them wild because they are the ones that were originally present in the environment, in nature, and they are not the same viruses that are then used for the development of the vaccines. It is important to recall that out of the 3 serotypes, there are 2 serotypes 2 and 3 that have been eradicated, and we only have wild serotype 1 that is endemic in Afghanistan and Pakistan. These viruses are highly transmissible, and it is one of the calls to action. But on the other hand, we have some other cases of polio that are the result of vaccine-derived polioviruses, also known as VDPV. And these viruses come from the vaccine virus that is included in the oral vaccine. And this is the situation when in populations that there is a low coverage, the virus is in the feces, it mutates and accumulates mutations that sometimes allows it to recover the virulence and once again lead to paralysis cases. So it is also important to consider that some of these viruses from the vaccine could be present in immunodeficient individuals or immunocompromised individuals. So when we have VDPVs, it is important to know what the situation is of those children, what their response is to the virus, and whether they can continue to eliminate the virus in their feces or whether they can stop this replication. After some additional studies on the viruses, these viruses end up being classified as circulating or immunodeficient or ambiguous, depending on whether they were found in other contact samples or environmental samples. And in those cases, we would say that they are circulating, or as I mentioned it before, if they are in immunocompromised individuals, they would be called VDPV. But if it is IVDPV, or they could be AVPD. So it is important to recall the context of the vaccines. Traditionally, the program found it very useful to work with two vaccines. The first one was the injectable vaccine, the IPV, that was introduced by John Salk in 1955. This vaccine includes dead viruses, inactivated vaccines, and it includes the three serotypes. It is an intramuscular administration. It could also be introduced intradermically, and there are no cases associated to the vaccine, and there is no risk of VDPV, vaccine-derived polioviruses, that may lead to AFP. But it is important that even though there is important or significant humoral immunity, the levels are not proper to stop replication at the bowel level, so there is no good intestinal mucous immunity that is recommended to generate higher immunity within the population. So we can say that IPV protects against AFP, but does not stop the replication when these individuals are reinfected with the poliovirus. From the point of view of public health, the development of OPV in the 60s by Sabin has been key for the progress made in the program for the eradication of polio. And OPV contains live attenuated viruses, and at the outset, the vaccine with the three serotypes was developed, but in 2016, after the switch, the type 2 was extracted from the vaccine, and currently those programs use the bivalent vaccine that only includes serotypes 1 and 3. But monovalent vaccines can also be found that include serotype 2, but we also have monovalent vaccines for types 1 and 3. This is oral administration, 2 drops with good humoral immunity and good long-term bowel immunity, and this is key to stop the transmission of the poliovirus. But we also need to remember that low coverage populations, in low vaccine coverage populations, the vaccine may revert to a virulent situation, and this is a vaccine-derived virus, and this virus in some cases may also lead to paralysis due to the host receiving the vaccine. Now, let us refer to the polio eradication program. Eradication usually is intended to reduce the worldwide impact of the disease caused by a specific agent because of the efforts we are carrying out, but also with the strategy of good surveillance in the area of AFPs. The good piece of news is that worldwide, the two serotypes, the WPV2 with the last case in 1999 was declared eradicated by the Certification Commission in 2015, and WPV3 had the last case in 2012, and it was declared eradicated in 2019. So these two agents do not longer exist on the face of the earth, and the only one that continues to be a problem for the program is the wild type 1. So these are the cases of the last couple of months, the cases that we see, polio cases generated by wild poliovirus type 1. We see the cases in the last 12 months and that are here represented in red for the program. Here in yellow, you can actually see the two endemic countries with the wild type, Afghanistan and Pakistan, and last year there was an import to Malawi that later on extended to Mozambique in Africa, and over the last couple of months, 6 cases were confirmed in Mozambique as a result of this importation. But here on the map, you can see the green dots, the polio cases generated by serotype 2, and in almost 19 countries, there are 475 cases over the last 12 months. And in yellow, you see the cases due to type 1 reported in 3 countries with more than 200 cases. From the point of view of the region, and also with this, we can highlight or show some of the milestones in the Americas. We see the map that we had in 1985 when the strategy was launched for the eradication in the region of the Americas. You can see here that each dot represents a polio case in the Americas, and you can also see that in the northern, central, and southern area, we had cases. The good piece of news is the last piece of wild poliovirus case was reported in 2001, in 1991, and then in 1994, we had the polio-free certification. Another important fact is that we had an outbreak of the circulating polio virus between 2000 and 2001 in La Española with several cases of polio, and where we started to see the possibility for the virus to revert and also regenerate these polio cases. But why is it important to refer to the surveillance of polio and also how to address surveillance of polio? It is important to mention that polio surveillance is carried out by means of a syndromic surveillance. That is to say, we carry out surveillance on the paralysis. Paralysis is weakening of the muscles, and it is flaccid paralysis. It is acute paralysis, which means that it increases rapidly. And fundamentally, this paralysis is seen in people younger than 15, and this is the age group that is the most susceptible, and where it is expected that the cases would not be the result of trauma or an earlier trauma. But it is important to recall that even though the objectives here, the targets here are people younger than 15, any people of any age with a polio diagnosis should be part of diagnosis and follow-up. So this also allows us to identify polio cases and also make sure that we do not have circulating polioviruses in the communities. So any case that is suspected as part of the surveillance needs to be investigated, and we also recommend obtaining a sample of feces for the lab diagnosis that will allow us to determine the presence of polioviruses. As we mentioned before, there are different etiologies that allow us to have differential diagnosis. We see some of these. It is important to note that some of them are infectious, but there are others that are not infectious and that we also need to bear in mind as part of this differential diagnosis of poliomyelitis. So from the point of view of surveillance, as we mentioned before, we started very early in the region. There is here a guideline that was developed by WHO telling us how to address the surveillance of AFPs to reach the elimination of polio in the region. This was in 1995. In 2005, this was updated, and it is the current guide. And now in 2023, worldwide, WHO has launched this new proposal for surveillance, where we already have the challenge within the regional office to update the guidelines. So we hope to have a new version with the guide showing us the actions, the novel actions that we need to include as part of surveillance of acute flaccid paralysis, and also as part of the guide that we have of 2005. At any rate, any case that is suspected of poliomyelitis, any case of AFP, would lead us to first analyze whether this is any trauma, and if not, we need to suspect that this is a case in which we need to obtain proper sample. This proper sample has to be obtained within 14 days of having initiated the paralysis. If this sample is not obtained, the next follow-up would be to determine whether there is any follow-up that we can introduce 60 days after the introduction of any sequela or effects due to the flaccid paralysis. If we have the samples, we need to send the samples for analysis, lab analysis and diagnosis, and then we can have the case classification that we will look into later on. This is a decision tree to investigate the case, where we basically need to think about carrying out investigation or research around the case. The file is completed with the clinical and epidemiological data, the sampling, and also we have the follow-up for the case, as I mentioned before, to assess the condition of the paralysis. And finally, this is done within 60 days. And there are other actions that need to be carried out at the community level. And this is something that has to be done by the public health team. And we are not going to decode all of them, but we will be sharing with you this presentation on the PAHO website for you to check later on.
As I was mentioning before, it's important for us whenever we suspect a PFA case, or if we have any fecal samples that are available for lab analysis, we need to get that sample no later than 14 days after paralysis onset. And it has to be at least 8 grams of fecal matter. Sizes that are preferable are 2 inches long. These need to be properly labeled so that when they go to the lab, that we don't lose the material during its transport. Of course, we need to maintain these samples under refrigerated conditions so that we can subsequently transport them to the National Laboratory for analysis. Rectal samples are not ideal because we cannot obtain sufficient material for adequate analysis in the lab. The diagnostic of poliovirus in the lab is one that is sequential. The first step is to treat the sample, we inoculate and develop cell cultures. And if we see any presence or any indication of presence of the virus, then we conduct molecular testing that will involve intratypical differentiation tests that will allow us to identify the serotype of the virus and if this is something that is present in the vaccine or not. If it is present, then we go on to some genetic sequencing tests. And once we sequence this with the VP1 genome, we can then determine whether it's a wild virus or a vaccine-derived poliovirus, or something that was already existent in the communities and based on its attenuated virus characteristics persists in certain regions. This highlights the importance of surveillance for PFA cases. So when we do suspect a PFA case, we need to ensure that in any case involving a patient 15 years or younger, that these are properly investigated. And we need to conduct the necessary lab diagnostic and the entire investigation on the epidemiology of the case. And at the end, what we want is to get confirmed, compatible, or discarded cases in the database. These are the outcomes for this process. In the cases that are confirmed, we have determined that it's an acute flaccid paralysis disease associated with the isolation of the wild poliovirus or VDPV with residual paralysis. In compatible cases, we're talking about a paralytical disease where after 60 days, the patient continues residual paralysis or the patient dies, in which we don't have a fecal sample during the following 15 days after the onset of paralysis. Discarded cases are those where we see acute paralytical disease. Adequate samples are obtained and analyzed in the lab and led to negative results. And so in these cases, we discard these cases as anything related with polio. There are some indicators in our surveillance efforts that allow us to determine the sensitivity of the system and the quality of the system that we have when surveilling for PFA. Now, when we talk about sensitivity, we're talking about the number of expected cases, and the estimated rate at present is at least one reported case for every 100,000 minors under the age of 15. Now, when we talk about adequate investigation of these cases, we want to ensure that 80 or more percent of the investigated cases are addressed during the first 48 hours after the notification. In terms of adequate sampling, we need to have these in more than 80% of the cases, and proper follow-up is deemed to be adequate when more than 80% of the cases are addressed after all of this process. Now, when we talk about performance for the surveillance of PFA over recent years, you can see on the left that when we look at the annual rate of cases compared to the expected baseline of one case for every 100,000 minors. In 2019, we were in full compliance of that baseline, but in 2020, we saw a severe drop, which was the year of the pandemic. This was improved slightly in 2021, and last year, we closed the year above the baseline. Nevertheless, in this last column, 1.16 represents the number of cases that we've identified in the last 52 weeks. And we see once again that this is a downward trend, which indicates to us that perhaps in recent weeks we are forgetting or we are neglecting to remain vigilant in these PFA cases. In terms of the percentage of PFA cases that are investigated, it's important that they be investigated no later than 48 hours after the report of the case. And this indicates that over the last 52 weeks, we have been above the baseline in this percentage. But when we talk about adequate fecal samples, the expected 80% baseline is something that we've approached and even gotten very close to, but we've not been able to meet that baseline level. And this is important because it provides us greater certainty as to the presence or absence of the virus in these samples. Something else that I wanted to share with you is an update of what's happening in the region. Unfortunately, last year, in the beginning of this year, we've seen 2 polio cases in the Americas region. Last year, in a young adult that had an onset paralysis last year, and we tried to identify whether or not this paralysis was caused by a circulating BDPV2 in New York, in the US, and eventually this virus was recovered in other samples taken of wastewater. This year, you may have heard about the presence of another polio case in a child, 14 months of age, that lives in Loreto, Peru. This child showed a paralysis towards the end of December of last year, and the case was confirmed in March of this year after the samples were sent to the laboratory, and the result was that there was presence of EDP1, PV1. Additionally, the presence of the circulating VDPV2 in wastewater is something that was reported in the state of New York last year. There are 5 counties where analysis has been conducted in wastewater, and the detection of PV2 has been observed. And this is what we suspect led to the case that was reported in New York. Additionally, we saw some wastewater analysis results in Quebec, Canada, and a number of communities, such as those in New York, showed the presence of the virus in samples of wastewater collected last year, which means that we have a number of threats that we need to be mindful of. I wanted to share this slide with everyone, basically to remind you about the polio bulletin. And several countries report the number of cases of acute flaccid paralysis in the Americas. And we can see all of the data broken down by country, the various indicators. And in the following page, we also see the current status of the cases that can be recovered based on the results. You could scan the QR code, or you can access the bulletin through the QR code. In terms of the recommendations for the team, countries need to engage in an effort to improve their performance with the collection of PFA samples as well as PFA surveillance. When the collection of the fecal sample is not possible within that 14-day deadline, then the recommendation is to collect a sample from 3 contacts. And this is one way of improving the surveillance so that these viruses do not become a greater threat than they already are. And I wanted to highlight the commitment that our group has towards maintaining the region free of polio based on resolution CSP 30.R13 issued in September of last year. And through this resolution, a number of countries committed to this objective, and we conducted a number of exercises to expand vaccine coverage, improve surveillance mechanisms, and be better prepared to respond to any outbreaks or any important events. Thank you very much for your attention. Thank you very much, Gloria. We've been reading some of the questions in the chat room, and they've been answered by Gloria. And I think we will take those words to heart. We have a commitment that we have renewed with all the countries to maintain the region polio-free, and we all play a key role and have a responsibility to contribute to this effort. So now we're going to move on to our next panelist, who is Dr. Marta Alvarez. She is the chief of the Pediatric Infectology Service in Bogota, Colombia. She's also the director of the Pediatric Infectology program at the University El Bosque in Bogota, and she's also a professor in various universities in that region. But more importantly, she is the chairman of the National Commission on the Eradication of Measles, Rubella, and other diseases. And she also works extensively on polio verification processes and programs. She will talk to us about her clinical experience and the challenges that we face in trying to address this deadly disease. Go ahead, Marta, you have the floor. Thank you very much. I think this is an excellent opportunity to share some of the experiences that we've had, and I'm happy to answer any questions that you may have. I don't really have any conflicts of interest to declare. I did want to share some information about a recent clinical case that we had in a 23-month-old child from Anapoima, Cundinamarca, a location very close to Bogota in a rather warm region. There were some negative perinatal testing The immunizations were up to date, up to 18 months of age. And from an epidemiological standpoint, I would say that the child did not have any issues with contact with pets or any symptomatic contacts. In March of this year, the child presented a fever, very high fever with dry cough and vomiting. We sent the patient to the closest clinical center. There were some viral tests that were conducted. The patient was sent home, but the following day, he still had a fever. He was weak and exhibited some sleepiness. He was then sent to laboratory testing, and an X-ray was conducted of the chest for potential pneumonia or neuroinfection. Subsequently, the child was admitted into a hospital facility in Bogota. The child appeared to be weak and dehydrated. So what happened when we got him at our facility? The child did exhibit sleepiness, uh, reactive pupils. He could be awakened with verbal stimulation, but there was a generalized hypotony that the mother could not uh, detail about as to when it began to appear. We saw some positive meningeal signs as a potential meningitis case. And we also looked at the child's reflexes in the lower extremities, which appeared to be rather high. Some of the testing that we did with the thorax did not exhibit anything. We conducted a cranial analysis at the institution, and everything appeared to be normal, both in the cranial exam as well as the lumbar exam. This everything appeared to be normal. There wasn't anything that we could see on the x-rays. Subsequently, we did determine that the child had acute flaccid paralysis, and we needed to transfer the patient urgently to the pediatric unit to be able to treat the case. And just to discuss what we did, the first thing that we did is what Dr. Gloria was mentioning. We first reported the case immediately. We filled out the epidemiological form and we collected the fecal samples. Additionally, we collected samples from other sources, including brain samples. Additionally, we conducted some joint assessments with neurology and other parameters. We had the intensive care unit team involved. We also conducted the clinical assessment and additional studies that included trying to exclude any additional infectious causes and autoimmune cases. And we conducted and contrasted MRI of the neuro axis, and we did detect some indications in the spinal cord, and in the brain area, it was mostly white matter that was detected. And we also conducted other analyses that permitted us to discard any additional presence of neuromuscular decay. We also considered the case to be one of botulism because it was reported that the child had consumed some honey. Nevertheless, additional testing did not yield any positive results. The only thing we saw was a positive result related to the respiratory system. We conducted a respiratory molecular test for enterovirus, which led us to suspect other etiologies. The sample was sent to the National Health Institute, and approximately 10 to 12 days later, the report was negative for poliovirus, and the patient was treated in a comprehensive way for neurology, and we provided some prednisolone. And in a couple of days, the patient was able to raise his head and was able to sit up. And the patient's condition has improved over time. And the important part of all of this discussion is that we need to conduct a proper follow-up and apply the adequate control methods. It's important for us to highlight the main objectives. We want to highlight and report any potential presence of poliomyelitis cases, as the doctor had already mentioned before. We want to illustrate the clinical characteristics of the acute poliomyelitis and any post poliomyelitis syndromes. I'm not going to delve too deeply and discuss the fact that this is a viral disease that is highly feared by for its neurological effects in the short and long term caused by one of the polio virus. We've seen millions of people that were affected by the virus during the 50s and subsequent decades, but thanks to the vaccine and its development, we were able to achieve a dramatic drop in the number of cases between 1950 and 1994 in the Americas region. And as the doctor mentioned previously, there's a growing concern about recent polio cases that have been detected and that could be VDPV cases. The polio virus, as we all know, is something that only humans can have. It is transmitted through fecal oral contact or through poor hygienic conditions. It could be transmitted through droplets or pharyngeal secretions or respiratory secretions. It can be eliminated in saliva up to 1 week after exhibiting any signs, and in fecal matter up to 6 or more weeks. It can be transmitted from people with and without symptoms. It can remain in wastewater for long periods of time, as we've seen mentioned in the cases of the US and Canada and London. Something that I wanted to emphasize is that people who are not vaccinated are the ones at greatest risk for paralytical polio. If they are exposed to the wild version of the virus, or if they are infected through oral contact, as the doctor from Peru mentioned, it can be very severe. This is a slide that seeks to highlight the importance of the duration of fecal excretion of the virus, the wild form of the virus in infected persons. And this highlights the reason why fecal samples need to be collected no later than 14 days after the onset of symptoms, though the virus itself can be detected up to 60 days after the onset. So what keeps us from controlling the disease? Well, some patients that are immunocompromised and have been for a prolonged period of time. I also wanted to emphasize that in every corner of the world, whether you have seasons or not, you can have transmission. In countries such as the northern hemisphere and the southern hemisphere, where they do have seasons, the disease tends to proliferate more during the warm months. but it is clear based on the evidence that the disease can appear under any circumstances, especially during rainy season. And we are talking about the viral or respiratory transmission of different viruses, not just that related to polio. So we see a very high contagion rate under these conditions, and 90 to 100% of the home contacts that are not protected or immune will then be infected. And this is something that seems to worsen the transmission of the disease, especially in urban settings. So this is just a slide related to a case reported in a child of vaccine-derived poliovirus. Now, when we talk about the clinical issues related to the virus, once the virus infects a person, it typically can infect a person through oral or respiratory means. It has an incubation period of between 7 and 14 days, and in 90 to 95% of the cases that will be in contact with the patient, they will be asymptomatic or will show or will not exhibit any symptoms. And this is important to understand because we need to provide adequate coverage for the paralytic patient. Now, when we talk about the respiratory or oral pharyngeal aspect, this can come into the intestinal tract. It can also get into the bloodstream. And at this time, we can see anywhere from 4 to 8% of the forms that we refer to, quote, as abortive. They could appear to be similar to any other viral process. It could even be similar to the flu, fever, vomiting, and even diarrhea. Nevertheless, when the disease then penetrates the central nervous system, it can then exhibit itself in two ways: in a non-paralytical way, in 1% of the cases, and this can appear to be similar to LCR virus or meningitis. There could be some symptoms in the neurological exam with certain signs that are similar to meningitis. And we can also detect the virus or the presence of the virus in the brain liquid. Now, in another small percentage of cases, we can see the paralytical form, and if the virus affects the vulvar part of the central nervous system, then we could see a much higher mortality rate. Something that we need to point out is that in 1% of the cases in the paralytical form, many symptomatic or asymptomatic cases may be present, which is of grave concern. So we have two different types of presentations. One can be very benign with symptoms such as the ones that I've already pointed out: fever, headaches, odonophagy, fatigue for 2 to 5 days. And these are symptoms that we see all the time related to other diseases. Now, the other more severe form of the disease could involve non-paralytical poliomyelitis over 7 to 21 days, where the symptoms include fever, headaches, vomiting, and these patients can recover at around 10 days. But the form that is more impactful is the paralytical form of the disease. And here it's important to note that typically we see a paralysis that is asymmetric and ascendant. There's a proximal dominance in the extremities. The extremities become flaccid. And from the clinical standpoint, in patients with paralytical polio, we have very intense muscular pain, especially located in the extremities. There is a loss of reflexes, and over time, muscular strength decays and they can atrophy after a certain amount of time. This form of the disease appears 1 to 2 weeks after the initial non-specific symptoms. So the patient can appear to have recovered, but then we see the more severe presence of more severe symptoms. And this can lead to cranial pairs. These are the pairs that affect the different areas of the brain, and this can be exhibited in different parts of the face. Difficulty in eating or swallowing. And the most important aspect related to the respiratory and circulatory system, if there is any presence in the brainstem, then this can lead to death. It's important to keep in mind the onset of pain and weakness because it can coincide and continue from the beginning. This slide is the result of the collaboration with Stop 53. This is a case that was detected in Uganda, and it demonstrates the appearance of flaccid paralysis without any notorious atrophy present. And here we see the asymmetries that are exhibited in the glutes here. And the muscles that are commonly weakened with polio appear on this left-hand portion of the slide. We can see how the extremities begin to weaken and atrophy. I won't delve into too much detail because the next speaker will be talking about this, but the post-polio syndrome is a neurological condition that affects polio survivors quite likely many years after the onset of the disease. And it affects anywhere from 20 to 85% of polio patients. The main marker is the motor system symptoms that are very evident. After such a large number of years, there's an effect and impact on other mechanisms.
So there is a persistent weakening of the muscles, there is fatigue, pain, muscular pain, and there could also be problems for eating and also general fatigue. This is important because this may also cause several neurological problems such as sleep problems, and they may need to resort to medicine to solve the situation. I also wanted to mention about the initiative to globally eradicate polio. We are fully committed, and the four main pillars are to strengthen routine vaccination among children and also following all of the recommendations at the country level and also at the level of PAHO that cooperates with all of these initiatives. So the idea is to implement supplementary immunization whenever necessary, in particular when the coverage in our countries has decreased, and also campaigns for sweeping vaccination, and also to continue with the surveillance of acute flaccid paralysis. As mentioned before, we need to have differential diagnosis clearly. And I would like to highlight that we need to have differential diagnosis also with other conditions, but until then, we need to have this in mind that this could happen with polio. The Guillain-Barré syndrome is common among 40 to 60% of the cases, and also transverse myelitis of the spinal cord in 17% of the cases. We have some other swelling cases that might be post-infection at the brain level and also at the bone marrow level. This is also important, but all of these differential diagnoses are important. For example, we don't often think of some of the symptoms, but in children that are younger than 1, we can see these cases of botulism. And it is important because we have descending paralysis, that is to say, from the top to the bottom. And we might have, for example, some situations such as consumption of honey, which is an important aspect, but also living in areas where there are many of the conditions leading to these syndromes. There are some other situations that need to be discarded clearly, once again, depending on the background situation as to the location of the lesion that is important, and all of the differential diagnosis has to be defined as to whether this is something that is compromising the nervous system. There is a brain compromise, and for example, to identify whether there is an impact on some of the cranium areas that we call it swelling or autoimmune diseases, or also compromise of the bone marrow. As we heard before, we also need to say whether there is any swelling at the medullary level, at the level of the bone marrow, and also at the muscular level. We also have several etiologies, and it is also important to know that polio has an impact on the anterior section of the bone marrow, but also there could be some other syndromes. Let me show you now, as part of the diagnosis, differential diagnosis, whenever there is a suspicion of polio. For example, in the case of our patients, I go back to the patient that had a fever, that had some of the meningeal symptoms, but different from what we see in polio. The person had reflexes, not only in the lower limbs, which makes polio less likely. In polio, we can see an increase in the number of the white cells. And there are other studies that can help us discard these cases. And with different studies, we can determine this at the level of the brain, of the bone marrow, and also we see the joint between the muscle and the doctors can diagnose and discard all of the symptoms that may lead to the problem, but clearly to continue to sample. Here we see another way to approach the problem. I don't think I am going to mention this because this is basically the same. We see some results and some findings in the bone marrow. Adults and older children can answer questions, and we can determine whether there is any alteration in the responses that they offer. So any There's different centers that can help understand whether the person has a tumor or whether reflexes are present, and also whether paralysis is symmetrical or not. If it is symmetrical, they can think of Guillain-Barré, or asymmetrical, it may be an indication of polio. Several aspects have to be taken into account, and regardless of the causes, we need to confirm and sample. Polio confirmation can not only be based on clinical findings. Other conditions have to be excluded, and also to recall, as I mentioned before, that not all of the polio cases have paralysis. Final diagnosis will include sampling of feces, and ideally within the first 2 weeks. But at any rate, there has to be sampling if later on, if it wasn't possible at the beginning, and also to determine clinically if there are no samples that they need to be taken. In the case of residual paralysis, this is a kid that has not been properly diagnosed. These are patients or children that continue with paralysis or with other alterations. And this also implies a challenge. Finally, I would like to share with you that each case of Flacid paralysis as identified also suggests the possibility of circulation of the poliovirus derived from the vaccine in our hemisphere, even though it is not the only one. Is it a diagnostic challenge? Of course it is, but it is very important to report each case of Flacid paralysis, because we cannot lower our guard. We cannot lower the number of cases that are reported. We need to continue to do this, and also to do some early assessments, and differential diagnosis is key to discard other cases. Thank you very much. Excellent presentation. Thank you very much for this reminder. An update on the clinical characteristics and the diagnostic approach of patients that have suspected cases of polio. I would like to remind all of the participants, even though it is in our chat, that the presentations and the recording of this session will be available and will be sent to the participants, and will also be made available on the PAHO website on immunization, and also in the YouTube channel for those who would like to hear this again, or those who would like to share this with other professionals. Now we are going to have the last presentation. This presentation will be done by Dr. Carlos Pardo. He is a neuropathologist, and he is also a professor of neurology at neuroimmunology, and also neuroinfectious diseases and advanced clinical neurology. He is also a professor of pathology at the School of Medicine, Johns Hopkins University in Baltimore, Maryland, here in the US. He focuses on neuroimmunological disorders with special attention on myelinosis and also multiple sclerosis, as well as other complications of infections. He is the main researcher within this department, and he has broad experience leading research not only in the US, but also with a view on public health regionally. I am going to give the floor now to Dr. Carlos Pardo to present on approaches, diagnostic approaches to differential diagnosis. Please go ahead. Thank you very much, Pilar, and I thank the Pan American Health Organization for this invitation. Can you see my slide? Dr. Ray and Dr. Alvarez introduced the problems we have with paralysis and poliomyelitis, and what I would like to complete over the next couple of minutes is an update on other neurological problems that may be found during the assessment and also the surveillance of acute paralysis in children. Clearly, the clinical presentation of motor problems, weakened motor ability, and also vesical problems are key for clinicians and also for public health sector, in particular bladder sphincter diagnosis. I just wanted to remind you that the spectrum of etiologies in connection with acute bone marrow problems also involve several factors that are key to bear in mind to establish a more accurate diagnosis. And here it is necessary to think of poliomyelitis or acute flaccid paralysis and other infection or immunity problems. In the next couple of minutes, I would like to review with you the concepts, the current concepts in connection with other causes of flaccid paralysis in children. And as Dr. Alvarez mentioned, it is important to establish an etiological diagnosis, but also an accurate diagnosis. We should recall that the most important part of the neurological diagnosis is to be accurate as to the location of the neurological condition, be it central nervous problem. And as part of those problems, it is also important to bear in mind the myelopathies, myelitis, and also it is important to think that there are some other traumas in the spine or vascular issues that may also lead to flaccid paralysis. And it is also important to bear in mind that peripheral nervous system problems such as acute mobility issues such as the Guillain-Barré syndrome may also have similar consequences to the ones we see with poliomyelitis in case of acute demyelinating issues. And the clinician, as well as the health and public health staff, need to be up to date with the differential diagnosis and this type of pathologies.
So what is it that we know up to now regarding the different causes that lead to paralysis issues in children? And I'd like to really focus on this slide for a moment because this is basically the most important summary of the presentation and the highlight of what I wanted to talk to you about. Over the last 10 years, we've seen some important progress in neurology, given that we've come to understand in a much more detailed way what pathologies and factors influence the presence of myelitis in children. Over the last decade, we have been more up to speed regarding acute flaccid paralysis symptoms. And this is something that is similar to other conditions, but this has allowed us to understand that there's an issue of myelopathies. So acute flaccid myelitis is something that was discovered in 2010, and it's associated primarily to D68 heterovirus. And this is perhaps one of the most important issues that we're going to have to be mindful of over the next decade in the Americas, because at this moment, the only epidemiological evidence that we have as to the presence of acute flaccid myelitis exists in the US. But in the rest of the Americas, we don't have a lot of evidence as to the existence of this, but it does exist, and it may be due to undetected cases that are the result of inadequate diagnostic tools. Nevertheless, we've seen other discoveries in the epidemiology of this myelitis, especially on the epidemiological side. And we see the existence of two uh, types of diseases. The first one, the ENMO, is basically the acronym to an antibody related disease that involves some proteins, and it creates similar phenomena to that caused by poliomyelitis as well as AFM. We have myelitis that is autoimmune, and this is unleashed in children through infectious diseases and through other causes. And the only way for us to do the adequate diagnosis of this is to look for this protein's antibodies. The other form relates to myelitis, optical myelitis, which involves an antibody that is attacking the spinal cord and the optic nerve, causing acute paralyses both in children and adults. And once again, when we talk about the spectrum of encephalomyelitis, many of these can be caused by viral diseases, but many others can also be associated with autoimmune issues such as the NMO. And the most important aspect of this that we're going to discuss is the role played by other important issues that are relevant to the Americas, such as the Guillain-Barré syndrome in children. We need to understand that this is a priority syndrome, as well as an important source of acute flaccid paralysis. And all clinicians need to be aware of Guillain-Barré syndrome to be able to differentiate their diagnosis involving children. And this can include vascular myelopathies, botulism, and other types of muscular disorders. Now, what infections are most frequently associated to myelopathies or spinal cord inflammation disease? We see a number of different bacteria, primarily brucellosis and mycobacteria. And mycoplasma is an important part of these myelopathies. And we also have parasites in the region that can produce acute and chronic myelopathy symptoms. Nevertheless, in most of the infection-associated myelopathies, we have a number of different viruses, DNA viruses, HSV, VZV, herpes, or CMV. We also have RNA viruses, those associated with West Nile or Zika viruses. We also have poliovirus, enterovirus D68, and Coxsackie viruses. These are the viruses that are most frequently associated with immune diseases and infectious diseases that lead to acute diseases. The other source of issues related to infections, not necessarily directly related to neuroinvasive diseases, but they could be related to immune reaction diseases or vaccine reaction diseases. And this relates to reactions of vaccines to different types of viruses, such as yellow fever, as well as others that have been discussed at length by Doctors Alvarez and Brain. I wanted to mention this because in the future, this could be a key branch of any surveillance effort undertaken in the future, to ensure that we undertake the proper diagnosis and differentiation of these different symptoms. When we talk about infection-associated myelopathies, we're talking about a delayed immune response against the spinal cord. These can involve cellular response or humoral response, and this leads to tissue and blood vessel damage. And we have the case of varicella zoster that produces damage in the spinal cord through this infectious poliomyelitis. And this can lead to acute flaccid paralysis. It's also important for us to keep in mind the temporal profile of selected infection-associated myelopathies. And for today's purposes, the most important thing is that the uh, acute poliomyelitis associated with enterovirus are broken down into hyperacute or acute flaccid myelitis, acute viral myelitis, which includes varicella zoster and other causes. These are very aggressive diseases, and the clinician needs to have a good understanding of the temporal profile of these myelopathies. Some other forms of the disease tend to be subacute and chronic. Many of these can be associated with retroviral or immunodeficient issues. I'd like to delve more deeply into what I had already mentioned regarding acute flaccid myelitis. Now, what is it? Many clinicians describe AFM as a new form of poliomyelitis. It's a disease very similar to poliomyelitis. We discovered, or at the very least, we emphasized the presence of this disease towards the beginning of the 2010 and more specifically in 2012 when we detected cases of AFM. And we noticed immediately that these cases appeared in the form of epidemiological outbreaks in 2012, 2014, 2016, 2018, which led to outbreaks of myelitis in different regions of the US. This form of myelitis associated with the circulation of enterovirus, in basic terms, relaxed, if we could describe it in that way, or waned during the pandemic. And it's very likely that the public health measures that were undertaken led to a reduction in the presence of the myelitis. We don't know what's going to happen over the coming months, but we do know that we need to be vigilant with regard to these enterovirus because otherwise we can see outbreaks of AFM. Now, many of these cases were associated with enterovirus, the D68 in particular, and this was related based on studies or genomic studies. And these were discovered in enteroviruses that had been circulating ever since 2010, 2012 in the states of Colorado and California in the US. Now, we've seen outbreaks of these that have been significant and that affect the respiratory systems, and this began in 2012 in the US. This is a reemerging disease because it's been reemerging for decades and perhaps even for centuries. But the association with acute flaccid myelitis was an important breakthrough at the beginning of 2010. Now, these acute flaccid myelitis cases generally occur in children they appear without any kind of gender preference or no sex predilection. It is more predominant during the summer season and the fall season, particularly in the US. Many members of the family and the household can be affected, but generally speaking, the pediatric patient is the one that exhibits the actual disease. This is a very aggressive disease. Some of the studies that were conducted retrospectively concluded that 96% of the patients had exhibited a very severe respiratory infection, or at least some preceding infectious disease. 80+% that were respiratory, and the other 30% that were gastrointestinal. Now, a significant percentage of these patients exhibited the presence of severe infection, and in many cases, this involved large segments of the lumbar region and part of the cerebrovascular system. After the outbreak in 2018, almost 60% of these patients, pediatric patients, needed to be admitted into ICUs. 26% ended quadriplegic. 42% had upper extremities paralysis. And so this new form of this myelitis that is very similar to poliomyelitis is something that we need to consider in our differentiated diagnosis of polio. And we see here these images of these intermediate care facilities. And this is a stark reminder of what happened during those years, with many patients showing muscular atrophy in a very important way. Now, the clinical studies of these AFM patients, in almost 85 to 95% of these cases, they have a prodromal fever or viral illness. Many of them exhibited upper extremities and lower extremities paralysis, which is characteristics of a hyporeflexia associated flaccid paralysis. Many of these cases involved paralysis of neck muscles as well as cranial nerves, and it also led to bulbar weakness and other issues.
So there may be also a sensorial type of syndromes, and the most significant characteristic, as Dr. Alvarez mentioned, and very similar to polio, is that these kids have muscle pain, which is quite intense at the beginning of the clinical syndrome. One of the most important characteristics of this disease is that all of these children have pleocytosis that is quite significant, with CSF, in particular when the CSF is sampled on the first week of clinical manifestation, and 35 to 40% of these kids have problems at the brainstem level. It is very important to note that the diagnostic tool that we have available, at least at the university level, is for an MRI of the level of this bone marrow to see the swelling of the gray matter in the spinal area, also in the anterior column, anterior horn. And as I mentioned before, this disease has been associated with enterovirus T68. In 2021, we established with several international centers diagnostic guidelines that you can review at the Lancet publication of 2021. But these diagnostic criteria include clinical neurological examination to emphasize on the clinical history and the neurological exam that needs to include the presence of flaccid paralysis and also evidence based on MRI and also CSF studies. So we also had to bear in mind that there are several situations in which there are hospital settings that do not have access to MRIs. So it is very important to have access to other elements, in particular respiratory exams and also nasopharyngeal samples to try to determine the presence of the enterovirus and also clearly samples of feces to determine the presence of other enteroviruses. So it is important to bear in mind what the criteria, diagnostic criteria are. And once again, you can visit Lancet page to review the criteria in detail. It is also important in many Latin American countries, whenever there is no easy access to MRIs, to obtain an analysis of the CSF and also to determine the presence of plerocytosis and also to try to obtain nasopharyngeal samples to have an approximation diagnosis for the problem of flaccid paralysis. The enterovirus as such in the US has some high peaks of circulation in June, September, between June and September. This is important because it is clearly known that other areas of the world, such as in Europe and after COVID-19, there has been an increase in the circulation of enteroviruses. We do not have a very clear idea as to the level of enterovirus circulation in Latin America. This is a graph showing genetic studies. This is a month old on the circulation of enterovirus T68 and also the few countries that have good genotyping of the virus. That would be the US, Canada, Mexico, and Haiti. But unfortunately, there is not enough data in other Latin American countries right now. These countries has clade B for the enterovirus. If you'd like to have access to more information on enteroviruses and mainly on acute flaccid paralysis, there are two pages with quite a deal of information. One has to do with the association that has a web page which is quite complete, and also the YouTube channel for this group. I am going to conclude with Guillain-Barré. Guillain-Barré is quite an important part in this differential diagnosis because most of the cases are presented in an acute fashion and they have a motor disease, which is quite important, and it is associated to viral and bacterial diseases, in particular with post-vaccine diseases. And Guillain-Barré in the differential diagnosis is very important, in particular because the frequency of Guillain-Barré increases in many areas of Latin America. Guillain-Barré, from the pathogenesis point of view, it is associated to an infection. The one that has been detailed the most is the one due to Campylobacter jejuni. This is a bacteria that causes diarrhea. Campylobacter jejuni also produces or is associated with Guillain-Barré because the immune reaction to Campylobacter jejuni also produces cross-reaction with epitomes that are present in the myelin of the peripheral area, and this is quite similar to the situation that we have, the situation that we see with the damage to the myelin and also the axon, which will also lead to paralysis due to the damage produced in the motor nerves, but also damage to other parts of the nerves, including the autonomic nerves. Guillain-Barré has different presentations, and for the purposes of the discussion today, there is a form that is extremely motor or that is related to sensory issues. But it is important to bear in mind because for the clinical evaluation, it is important to have a detail on the distribution of the muscle weakness, and also in this graph, we clearly see the different types of Guillain-Barré that we can see in the population. And also in Latin America, we have seen over the last 10 years, two important outbreaks of Guillain-Barré, mainly that was in 2016 with the Zika outbreak that was associated with Guillain-Barré, and in more recently in Peru with two outbreaks in 2018, 2019, and many of them also related to children. There is no epidemiological evidence that coronavirus might induce to some cases of Guillain-Barré, such as Zika or Campylobacter. There are some sporadic cases, but the relationship between Guillain-Barré and COVID-19 is very weak. It might not be important either. So there is a summary that is published in English and in Spanish, and I invite you to review. And these are the 10 steps to bear in mind when we find patients with Guillain-Barré. It is very important to have a clinical approach to an accurate diagnosis. It is important to differentiate it from acute myelitis and also other types of flaccid myelitis, in particular systemic problem, volutism, or other damages to peripheral nerves. In this review, you can see the criteria to accept patients to intensive care with a plasma exchange or immunoglobulin, also how to monitor patients and how to follow up the clinical characteristics of the disease. I invite you to review this publication that can be freely accessed to everyone who has access to internet. The most important message is that Guillain-Barré in Latin America is something that has to be borne in mind. We have Guillain-Barré associated to Zika and chikungunya, but the one we have currently is associated to diarrhea, Campylobacter june, and it can be also close to polio, suspected polio cases, and many of these cases that are also included in the surveillance of acute flaccid paralysis that are also associated with Guillain-Barré. Finally, I would like to mention a disease that may be a little bit strange in Latin American countries, but we are paying close attention to this in centers where we have access to immunological studies. MOG, or myelin oligodendrocyte glycoprotein. This is the rediscovery of this that leads to two types of conditions, myelitis, and the other one is the demyelinating disease, disseminated disease that also is similar to flaccid paralysis cases and also myelitis cases. The only way to have an accurate diagnosis of this disease is by establishing an immunological diagnosis by detecting the antibody against this glycoprotein. And right now, the access to that diagnosis is only by means of specialized studies such as the Mayo Clinic, and it would be very important to try to initiate a program to improve immunological diagnosis of immune diseases in Latin American countries to clarify etiologies and also to determine better diagnosis. Dr. Alvarez also mentioned botulism once again. Botulism is an important cause of acute flaccid paralysis, not only because it is associated with food poisoning, but also child botulism is important to be borne in mind. Once again, thank you very much for the invitation. If there is any question or doubt, please send me an email and I will be happy to clarify any doubt you may have. Thank you, Pilar. Thank you very much. Excellent presentation as usual. Carlos, very good illustration that gives us a very broad view of differential diagnosis without losing our focus on diagnosis and clinical management of patients that have suspected polio, given acute flaccid paralysis and neurological issues. We are going to select some very brief questions that we have received in our chat by the participants to offer a short answer by panel members. So I give the floor to Dr. Magariños. Thank you, Pilar. Just we tried to answer most of the questions directly, but if there is anyone missing, we'll send you the answers. We have a question for Gloria. This is something that was indicated, but once again, how long does the virus survive in the environment after it has been excreted in the feces? So can you answer?
Thank you to Edna for her question. Generally speaking, the capability to survive in wastewater for the virus can be up to 2 weeks, but we've seen cases that describe that the virus can be viable for up to 2 months in wastewater. Many times it depends on the condition of the wastewater, the presence of other contaminants, be they chemical or of some other nature, can affect the survival rate. But as the Dr. Marta mentioned, it is a prolonged period. It can range anywhere from 2 weeks up to 2 months that the virus can survive in that medium. Thank you, Gloria. Dr. Alvarez, I have a question for you because it came up when you were making your presentation. The post-polio syndrome, how long or what time period can transpire before the virus appears again? Well, I didn't want to mention because I thought that my colleague was going to talk about this, but many times it can be several decades after the initial condition. It could be a case where the paralysis was not significant, but it then appears much longer, especially with people who are active or engaged in athletic activities. But in many of these cases, with age, people start to feel muscular pain and progressive signs of that relate to polio. And if we don't have a clear-cut understanding of the background of the patient, then it's very difficult to relate that or connect that to the polio suffered much earlier in life. In many cases, children had some transitory or temporary condition, and they then go for a long period of time feeling relatively well, and then we see the reemergence of the symptoms. And many times people try to look for explanations. They look for psychopharmaceuticals. The patients start feeling fatigued and they start suffering other disorders such as sleep deprivation or depression. And they try to get drugs to treat these conditions, but that often obfuscates the presence of the disease, which can reemerge many years after the initial onset of the disease. The post-polio issue is really interesting because in many of our cases right now with AFM patients, we try to track these patients and look at their follow-up very closely. But post-polio became a clinical problem in a lot of people. We studied the virology, the immunology, and everything related to the disease. Now, what we've concluded in recent years is that the post-polio syndrome is likely associated, like other neurological diseases, to a decay in the spinal cord or the reserve in the motor neurons in the spinal cord. So as we age, these reserves in the spinal cord deplete with aging. And if a person has suffered polio or has had a different spinal cord disease, then it's likely that that person will experience a much more pronounced decay in the spinal cord with age, or if there are other factors such as infections or other comorbidities that could affect the metabolism of that particular patient, then this could also be in play. So the syndrome is more clearly described as a depletion in the neurological or neuron reserves in the spinal cord. I wanted to add something to the prior question that I do believe is important to clarify, especially when we talk about fecal excretions that contain the virus. We've seen cases involving patients that have humoral antibodies present, especially in persons or children that have been diagnosed with certain conditions, mostly male, that don't have the capability of producing antibodies, and they have the capability of excreting for long periods of time, in many cases years. And it turns out that there are reservoirs that have perpetuated the presence of vaccine-derived PV, because in many of these cases, the patients have been vaccinated, but we have found years after the fact very specific symptoms. I have a number of patients that suffer from these amagonum that affects the hemoglobin system. And these were people that were vaccinated in a timely way, primarily with the oral form of the polio vaccine. But after a long period of time, they start to see other issues. Thank you, Marta. Pilar, I don't know how we're doing on time. There's a very short little question for Dr. Pardo that inquires whether the vaccination status of the patient has any type of influence. And after that, we wanted to also mention some comments directed at you, Doctor, regarding your willingness to participate in certain issues. Well, the first question of the first part of the question was any association between AFM in children. The question is, what was the vaccination status of those children in those cases? Well, based on the series published in the US, most of the children had been vaccinated. That is, there's no evidence that they were not protected by vaccines. Now, this is an interesting question because in other countries, particularly in Europe, they have conducted more detailed assessments in that regard. And something that we know and something that's happening at the present time in Turkey is that our Turkey colleagues and neurologists and infectologists are treating immigrant populations from Syria. And what they've found are sporadic AFM cases that they unfortunately have not been able to associate with as enterovirus or some other type of virus. But in most of the cases, at least in the US, it involved children that had been, in fact, vaccinated. Very well. I yield the floor back to you, Pilar. Very well. From the Pan American Health Organization, we'd like to just go on to the closing remarks that will be given to us by Dr. Daniel Salas, the chief of the immunization program at PAHO. Yes, thank you very much. Thank you very much, Pilar. And once again, I wanted to reiterate our appreciation to our speakers, Doctors Ray, Alvarez, and Pardo. I think we all agree that the presentations were excellent. They've contributed an enormous amount of information, experience, and accumulated knowledge that has proven to be very helpful and will continue to be so in this new launch that we all have to undertake in our countries to be able to improve our diagnostic capacities, our surveillance mechanisms, and other efforts to control not just polio. When we talk about this differentiated treatment approach and research, we're starting to deal with other pathologies that have been very impactful in our region and that had been neglected from the research standpoint. For example, this disease described by Dr. Pardo, acute flaccid myelitis. But I think we leave this webinar feeling much better informed, and I think that this is something that will really lead to some benefits to everyone. Dr. Pilar mentioned that we're going to be sharing and disseminating this information and knowledge through our various social media channels and through our various networks to increase and improve awareness in all of our countries. Thank you to everyone who joined us today. We cannot allow polio to continue to circulate. We cannot allow more cases to affect our residents in any of the countries. Thank you for joining us today.